This is MedChat, the podcast that's almost as healthy for you as a kale smoothie. Our guest tonight is Dr. AJ Mencias, a 51-year-old renowned hand, wrist, and elbow surgeon who currently serves as the president of South Bend Orthopedics and Sports Medicine, a partner practice of Ortho Alliance. Dr. Mencias is widely recognized for his expertise in treating complex hand, wrist, and elbow injuries, particularly in high-level athletes. He holds the position of Director of Hand Surgery for the University of Notre Dame Athletic Department and serves as a consultant to major orthopedic companies. Outside of his medical career, Dr. Mencias is a man of many passions. He's an avid golfer and workout addict at Orange Theory. He also has a keen interest in watch collecting and is a big fan of Dave Matthews Band, Coldplay, and old school hip hop. Dr. Mencias loves to travel with his wife and children to the beaches of 30A in Florida, occasionally indulging in cigars and old fashions. Additionally, he has a great appreciation for the business side of medical medicine, particularly the intricacies involved in managing a large private practice orthopedic group. So we've got a lot to cover, so let's dig in. AJ, how are you doing?
I'm great, Mike. Doing great. Thanks for having me. This is exciting. This is knowing what we're going to talk about. I'm excited about it, stuff that I'm passionate about.
Because we have to cover, since this is a spirited discussion on healthcare, are you participating in a adult beverage right now?
I am. I got a little Basil Hayden's right here. I don't have my big ice cube because I can't find my ice cube mold, but I have a bunch of tiny little ice cubes. So it's still working. It's still working good. So
I'm
what are you
drinking
drinking?
a little Rioja. And I actually one-upped you a little bit, and I have a full cheese plate for my...
Oh, that's way cooler than what I'm doing.
Getting into the business side of things,
Yeah.
we'll get there later, but some of the things I like to do on these is have people get to know you a little bit better. So just throwing it out there, books that you're reading right now, or maybe a book that you recently read that you would recommend to our listeners.
I'm really into the Navy SEALs. I don't know why. I like their attitude, which is identify a problem and go straight for it as fast as you possibly can. And so I like that attitude. It's kind of what I try to do instead of overanalyzing, avoiding it, going around it. I just go for problems. So there's a book called No Easy Day. It's by Mark Owen. Mark Owen was a SEAL Team 6 guy, was involved in, taking out bin Laden when it occurred in Pakistan. And so it's called No Easy Day. It's a fantastic book.
So the other thing I like to ask is, what is the best thing under $100 that you've bought in the last, 30, 60 days?
Well, I've been having a lot of foot pain recently. So talked to some people I know, and they recommended OOFOS, OOFOS footwear. And as it turns out, our Notre Dame training staff and some of our athletes wear OOFOS footwear. So I got some OOFOS recovery clogs, and I wear them around the house. And it has revolutionized my foot pain. So awesome. $79 online, you can buy it. OOFOS footwear. I love it.
We do not have a promo code for that yet, but I will link OOFOS in the show notes along with the book recommendations. No, maybe they'll be our first sponsor. Who knows?
Absolutely.
So I want to get into the business side of things here, because that is really what you like to talk about and you're focused on. Give us a background of what you do exactly at South Bend Orthopedics, what your role there is, and then tell us a little bit about the practice.
Well, I've been at South Bend Orthopedics since I think 2004. So I think this is my 19th year there. For several years, I really wasn't involved in leadership of the group, but maybe 10, 12 years ago, I got really heavily involved in the leadership of our group, joined the executive committee, and a few years back was elected president of our group, managing partner of our group. And so really the day-to-day operations I'm heavily involved with, our management team, and really heavily involved in HR decisions, financial decisions, strategic decisions, relationship in the community type decisions, and just day-to-day partner issues and business issues. So but also at the same time, I try to be a full-time doctor, which I am, and see patients and do surgery and manage my own personal practice. So it's a juggling act, and but I enjoy it. I never thought that I would enjoy the business side of medicine as much as I do, because I think it's important and you have to be engaged as a leader. And it is a full time job. So you have to look at it as a sacrifice, because it's a full time job before my full time job of being a surgeon and after my full time job of being a surgeon. So it is starts early and ends late, but it's, the price that we pay, but I love doing it. So our group's been around for 75 years. Um, we have really been through all of the healthcare, I think, ups and downs over the years. We persevered through COVID. We didn't lose any of our employees. In fact, we made the decision to keep all of our employees and take care of them and do what we needed to do, because we knew COVID eventually would subside, or at least the pandemic would subside, and we would still need to see the influx of patients that was going to occur when that happens. So we have all the specialties in musculoskeletal medicine. We have neurosurgery. We also have a plastic surgeon. We have anesthesia. We own our hospital with another partner. We own our surgery center with Ortho Alliance. Ortho Alliance is a recent transaction we did. So hopefully we can get into that. But our group is very strong and solid, but we've encountered challenges, and those challenges became extremely apparent during COVID. And I think they will continue in healthcare and for private practice groups. It's unavoidable.
So let's talk about that. So I do want to get to the private equity group that you just did a deal with, and talk about the genesis of that, and dig really deep into that. But the challenges during COVID, can you talk about those from kind of the minutia all the way to the major stuff, and what you had to go through, and kind of how you came out of it?
Well, I'll just start with the virus itself and the illness. We did have several of our partners and our employees really did, with the initial COVID surge, became quite sick. I mean, it is and it was a real disease back then. And the thing was that the information that was coming from the authorities was changing every minute of every day, and we were not equipped to manage that. We had frequent meetings, and even to the point of, should we close? Should we not close? Well, we need people. Patients need to be taken care of for their emergent problems. But so we were able to survive based on really emergent problems, things that needed to be fixed, and it allowed us to continue to stay, semi busy and semi solvent. But the one thing that really was tough, we were not used to having, we weren't having the same cash flow and the same revenue that we were used to, but we made the conscious decision to keep all of our employees. And several businesses, healthcare businesses in town, chose not to do that. The other thing is the amount of, I think, work hours that our administration had to put in, synthesizing all the information and giving us the best advice possible. It was very tough on the system, when we clearly, as a healthcare community and as a healthcare community, as a country, we weren't ready to deal with a pandemic, even though we've talked about it many times. It just, historically, there have been many pandemics, but surprisingly, we were not ready to deal with it. So then COVID, the other thing, from a healthcare, running a private practice, owning a private practice, it did affect insurance companies. It affected how they paid us, how we submitted bills to them. There were delays. So not only was our revenue, because of our volume being down, was it low and affected, but the insurance companies were affected. And then people just, we lost over the year. I mean, just over these last 2 years, just the volume of people wanting to be in healthcare completely dropped off. And then what happened? Yeah, go ahead. But and that after that created a wage war between private practice groups and hospitals and large healthcare systems. And you know who's going to win that wage war. And then that created an artificial elevation of salaries, which is truly unsustainable. So it's
Yeah.
the minutia of it is unbelievable, and it was a real disease. It was a real problem. We weren't prepared for it, but it will have lasting effects. Part of those lasting effects was probably one of the convincing things that led us down this private equity Ortho Alliance transaction. So.
Yeah, and I don't have the alternative or the equal stat for this, but for physicians. But we had a presentation today by a consultant, and they said that there is 245,000 unfilled nursing positions in the U.S. right now, and the wage war that you mentioned. One of the consultants was saying, well, these hospital systems were bringing in nurses and paying them double, triple their regular wages for their full-time employees. And then the FTE started going, well, why are we not getting paid that? And so there was this constant battle, and then the burnout, and just hospitals sometimes are not the best places to work. They were also talking about scheduling, where a nurse would work from 3 to 11, and then they'd say, be back here again at 7 in the morning. And it's like, well, that doesn't make any sense. And so,
No.
And I'm not blaming hospital systems. There's a million things that a hospital CEO and a C-suite is thinking about, from how to take care of patients the best, to whether or not they should have the French fryers on in the cafeteria at 3 o'clock to serve healthy food or not. So there's a lot that they're going through. But you mentioned that COVID experience and some of the challenges that you faced there, being a catalyst for pursuing private equity. To the extent that you're comfortable, can you kind of walk us through how that came to be?
Yeah, I had about hospital systems. It is, COVID started March of 2020. We're now March of 2023, 3 years later, and the large health systems capacity, they can't run the same number of rooms. They don't have the nurses. They completely changed their anesthesia delivery models. It is a drastic change from where we were in 2019. Healthcare was roaring in 2019. Our group was roaring in 2019. So we talked about declining reimbursement, and I can tell you, I believe the large health insurance companies still haven't returned to normal, because I believe they don't have the workforce that they used to have to process claims and pay the bills. Private equity. So in July,
Well, we're going to get into reimbursements in detail later.
We were
So I know
approached
that's
by a group, an
point for a lot of
MSO.
people.
For those that don't know what that is, a management services organization called Ortho Alliance. Ortho Alliance was a group that started in Cincinnati with a large orthopedic group called Beacon Orthopedics. And they approached us, and we knew some of the people. There were some relationships there between some of my partners and some of the other doctors about, hey, are you interested in a partnership? Ortho Alliance is backed by Revelstoke, a private equity group out of Colorado, Denver, and very good reputation, other healthcare platforms. And the big thing that Ortho Alliance sold us on, and I believe it to be so very true in talking to their other partner practices, is they would give us the support, the infrastructure, the data analytics, the capital that we needed to compete on a big time scale. And we really liked them because they had a regional play, really acquiring and managing groups in Ohio, Kentucky, and Indiana, and hopefully one day in maybe Southern Michigan. But they really wanted to bring on and acquire successful groups that just needed tweaking, that needed a little rigor and a little discipline. And I thought that our group, we really needed a little more rigor, a little more discipline, but we also needed infrastructure. We needed support. And in today's world, healthcare is consumer centric. It's about consumerism, and private practices are not based on providing and focusing on customer experience, patient experience. And I know that a larger entity can do that. And also there's this concept of omni-channel healthcare. I mean, CVS, Walgreens, Best Buy, Amazon have already created their own healthcare systems. Some of them are partnering with large health or large insurance companies. So for our group to compete on that scale, and for a lot of other reasons, we thought that this private equity transaction into the Ortho Alliance MSO made a lot of sense. And the whole goal of Ortho Alliance is not to affect our clinical practice. It is to allow us to continue to provide high quality care without all of the business concerns and business issues that we have that we just cannot. They continue to get piled onto us, Mike, and it's impossible to keep up with it because at heart we're doctors. So
Right. Yeah, and you touched on that earlier, really wearing two hats, right? So you're working the business side of your business because this is not a set it and forget it type of a business. This is something that needs attention, that needs management, that needs leadership. It is something that needs business development. And then you also have to go and do surgeries and all of the other things that you're doing. And so being able to shed some of that stuff to where you can concentrate on providing care and doing surgeries, I assume was a big part of the reason that you did that.
yeah, and those of us involved in leadership, those of us on the executive committee and certain boards that we're on, we just knew we couldn't keep up. And like it or not, with with the fact that our reimbursements are dropping, the only way that we can keep up and continue to be productive members of our group and productive members of the medical community is to work a little harder in medicine. And then the other thing that this Ortho Alliance transaction helps us to do is to keep. I mean, it requires different leadership, not the leadership of medical groups from the 90s and early 2000s, but ever evolving leadership. There's so many new concepts that pop up every day and things that we, as physicians can't keep up with. It really requires leadership of a different type, quickly adapting to the business landscape and just quickly responding to different changes in regulations and rules that happen every single day, every single week, every single month. And it is not our forte in doing that. It is the forte of a business organization. That is their function is leadership in the business world. And so it's, to me, it was the best decision we could make to keep our group surviving and thriving for another 75 years.
Okay. We'll get back to this, but
yep.
Talk to our audience about the business of providing care as a private practice. And so how does it start? How does it evolve? I understand that you just took a big step with private equity, which is going to hopefully supercharge your business, but give us kind of a day in the life of running a private practice.
Well, I want to go back to the way it was when I started in 2004. We had paper charts. We had a single bill sheet. We had a folder we'd open up. It was all right there. There were no technology glitches. I don't even think we had Wi-Fi in our office. So it was very simple. We'd see a patient. I'd dictate on a dictaphone. I'd write something on a piece of paper, and that was it. That was the encounter. Now, the encounter starts, and everyone experiences this in healthcare. You come in, you got to fill out all the same paperwork that you did a month ago because there's new regulations. We got to scan your insurance card, scan your ID. Then you come back and see the patient. You see the physician who may be behind because their schedule is more full than it likely should be. But then we have a medical assistant that enters all the health data that may or may not apply to the reason they're visiting me, because those are the rules that are now in place. And then after all that, and you enter everything, and you still are not fully EMR, electronic medical record, you're still using a lot of paper for an EMR, then the doctor comes in. The doctor comes in, and you either have a choice to enter all the work in the computer yourself, which means you can't talk to the patient or examine the patient or even face the patient, or you dictate into the cloud, which then puts it into your electronic medical record, or you have a scribe. which is what we have. And scribes are extremely important in allowing us to see patients efficiently, still give them the experience which they deserve, which is to examine them and talk to them, because it's about patient care and patient experience and giving them the best care. And I don't know how to give great care while looking at a computer. I just don't. But it is our mandate to use EMR because of a concept known as meaningful use, which there are a lot of good points to meaningful use, and that was set in place by governmental agencies. But I do believe in some of the good points of meaningful use. But a lot of the rules and stuff that we do are because of that. And then if I decide someone needs an MRI or a surgery, then we have to go through an authorization process. Before we would prescribe or order an MRI or do surgery, it was quickly approved.
By the insurance
Very
companies.
quickly. By the insurance company, by the payers. And now there are so many hoops to jump through. And just speaking selfishly as a physician that's been in practice for 19 years, I would like to believe that a patient believes and understands that I would likely know and have the knowledge base to decide whether or not an MRI is required. And unfortunately, there are a lot of rules that say when or not an MRI is required. And sometimes you have to order therapy when, in my opinion, it's not indicated. Sometimes you have to do a bunch of stuff. So, and then there's this thing, I wrote this down because it's one of the most ridiculous portions of medicine in my belief. It's called a peer-to-peer review. And when I order an MRI, I sometimes have to call a physician that's often not an orthopedic surgeon. In fact, the majority of times is not an orthopedic surgeon, and justify why I want to order an MRI. And I do know physicians in the world that are friends of mine that say, I'm not going to ever do a peer-to-peer. So guess what that means? Their patient isn't going to get that MRI because that won't, unless you do that peer-to-peer, it won't get done. And in 19 years, or it's actually been an occurrence only really over the last 5 to 7 years, I've never had anyone reject my order for an MRI. So it's just a hoop you have to jump.
Mm-hmm.
So it makes it complex. And I don't know when I'm supposed to do a peer-to-peer, but I find time. And then you, same thing with surgery. And then there's sometimes we do surgery on people, the surgery gets canceled the day of because we actually didn't get the authorization to do the surgery for an urgent problem. There is no explanation for that. I can't understand when someone has a significant injury that affects their quality of life and their ability to work, why I would get denied the ability to do that surgery. It makes no sense to me. And it happens a lot. It happens to me once a week. Today it happened to me twice.
I don't want to.
Yeah.
I don't want to make insurance companies out to be the bad folks or the payers out to be the bad folks, but are they? I mean, is this an issue that is the payers that are just trying to save money? Or is it that they really just don't trust the doctors to be ordering the procedures that they feel their patients need? I mean, it seems like you guys are the best people to be recommending a certain procedure, an MRI, a surgery, right? You're not doing it to because you want to effectuate the best care for your patient, right? And to have to go through all these hoops, I mean, it's frustrating just hearing you talk about it.
I would say, Michael, that I know insurance companies have a job to do, and what they're trying to do is prevent overutilization. And I get it. I think that if you're being a good steward of resources, which most of us believe that the cost of healthcare is too high, so we're trying to respect it. But I'll just give you an example. I would think that there is some worry, and I get it, that we own our own MRI machine. We act over that, which says, man, these guys, are they overutilizing? We know they make money off their MRI, but the American Academy of Orthopedic Surgeons came out with a study that shows physicians that own their own ancillary services like an MRI do not overutilize. In fact, we, on average, order less MRIs than those that don't, because we're purely respective of that fact. So, and insurance companies have a business to do like I do, and I respect that. I do. But it's multifaceted. I've heard of a concept known as a gold card. It's, for lack of a better term, surgeons that have shown appropriate utilization over their careers, have had good results, have had good patient outcomes, have had high patient satisfaction, can eventually, I know this concept is occurring and it may occur at some point, then maybe we get a free pass to know that our tests are ordered appropriately, our surgeries are prescribed appropriately, which I think is a great thing. If you track correct, yeah, you know?
Yeah, it seems like with value-based reimbursements that you would see outcomes, and then you could go to that physician and go, well, he's got a very good track record. He ordered this MRI, he ordered this surgery. Now the patient is on the mend, and we're seeing them less often. Then having them come in 2 or 3 appointments, do PT, do some other sort of treatment that doesn't solve the problem, and then you end up back at the same spot, but you had to go around and around and around before you got to that outcome. And I hear what you're saying about the insurance companies having a responsibility and understanding that there is a lot of Medicare fraud in the healthcare industry, and so I could see both sides. But I'm talking to you right now, and I feel your pain, and it's a rabbit hole that you could go down very, very deep. But you're on the front lines and you're talking about it, and it makes a lot of sense that you shouldn't have to go through that. Let alone, we can get into this, all the coding changes and the reimbursements, and maybe this is a good opportunity to get into that because that is I have physicians that live around me. I'm in the business of healthcare real estate. We have a lot of doctors as our tenants and physician groups. And this is the number one thing when I actually sit down to have a dinner or a drink or coffee with a doctor, it's reimbursement rates. And the fact that your education has progressed, which, by the way, I feel bad that I did not talk about your education, but I will. Maybe it's because I'm a Michigan guy and you're a Notre Dame guy.
Can you call that education? Let's really talk about.
Well,
okay.
I didn't go to Michigan. I'm just a Michigan fan. Let's be clear. But the education that you guys continue to get, the experience that you can continue to get, the improvement in your outcomes over time, but yet your reimbursement for what you're doing is going down. So let's talk about reimbursements. What is broken about it?
It's a broken system of how you even negotiate a contract. I think that we used to believe as doctors that if you collect data to show that your outcomes are better, your reimbursement will stay up. And what I've realized is even in a single state, the reimbursement for one procedure is different virtually in every township, in every town, in every region. And I don't even know, and that's just because we as doctors talk. I don't know how that could possibly be, but the thing is, I don't think doctors, unless you have a robust business office and a robust group behind you working on negotiating your contracts and making sure they're maximized, unless you have that infrastructure, most doctor groups are just going to accept the contracts they have. And the unfortunate part of that is if your contract stays the same and inflation goes up and wages go up and your cost of business goes up, it is an untenable situation. And a lot of times I've found myself in negotiating with insurance companies. Again, I'm not trying to make them out as the bad guy, but when I try to explain that our expenses are going up and it's just harder to do business, oftentimes it falls on deaf ears. I would think that if a group is doing a good job, we have patient satisfaction, we have great outcomes, we should be rewarded for that. And oftentimes, I'll give you an example. How I fix a lot of broken bones. You would think that when I put a plate and screws in someone's bone, you would assume that that plate and screws is a necessary portion of the procedure. It is absolutely necessary, but yet there are insurance plans that don't pay for those implants. So I don't know how we can remain a positive, viable entity if even the basic implants that we put in people are considered unnecessary and they won't pay for them? I mean, what that is, that is just so, it's just so counterintuitive. We're trying to do our best job to take care of patients, get them back to work so that they can be productive members of society. Yet it's a very real struggle. But what's broken is everything about it, Michael. Everything about it. How we negotiate, how things are paid to us. Are they paid in a timely manner? You know, if, for example, I get a pre-authorization for some CPT codes that I think I'm going to do. Yet I do something different because when I get in there, it's the opposite of what I plan to do. Your case may be denied because you didn't, and it may or may not, you may or may not get paid for the work you do because you didn't pre-cert for the right code. It just, it gets old, and it is fatiguing to doctors, and it leads to burnout, and it leads to people just leaving the medical field. So I don't know. There's just so many things about it that are broken, and maybe doctors are to blame too. I mean, I don't know the answer to the question, but a very large portion of the system is broken.
So why is healthcare so expensive? If you go into a hospital with a strep throat and they have to keep you overnight and you don't have insurance and they bill you the next day and it's $12,000 because you stayed a night in the hospital, why does it cost? Why does that happen?
Well, a hospital has rent to pay. They have a ton of staff to pay. They have a ton of overhead to pay. Their supply chain is expensive. They just have a huge amount of overhead, and but also they're in the business of making money, and what people don't understand, and I try to explain this even to my wife or friends that are not in healthcare. You know, outpatient everything is much cheaper than inpatient anything. I try to explain that to them, and then why? It's the same doctor, it's the same healthcare you're getting. It's just that person doesn't have insurance. They have to go to a hospital. This person can go to an outpatient clinic and get the same care. And it's 3 times more expensive as a hospital. It's just the hospital overhead's expensive. There is just so many more steps and so much more complexity to inpatient hospital care. And you know, knowing what I know about hospitals, because we do own our own hospital, the regulations that go into running a hospital are unbelievable. And so I think those regulations, those rules, and all the steps and people that are put in place to make sure every rule is followed, every I is dotted, adds cost to healthcare. And, you know, truth be told, the same procedure at an outpatient facility is 1/3 the cost of a hospital. Even if you do it as an outpatient, if you center versus the same procedure, me doing the same procedure in a hospital, it literally costs the healthcare system 3 times as much. And I don't, other than overhead, I don't know what else it could be, unless there's an extreme desire to just have a much larger margin. I don't know the answer to that. And that's one of my big things. I hate talking about margin when I talk about caring for people, but it's a fact. You know, I guarantee business people at a hospital talk about margin. They have to. And but that's one big factor. Hospitals are just more expensive to run, and I know this because we own a hospital.
So we've talked a little bit about things that aren't working. What is working, like within our current system? What's positive about kind of your day-to-day interaction in the healthcare industry?
Personally, for me, what's positive is I love talking to patients, and patients in general love talking to me. They like to interact with their doctor. And in the United States of America, we can provide the greatest care ever, ever seen by people, ever seen by patients for very complex problems that 19 years ago we couldn't fix, we didn't have a good answer for. And we're very good at getting, from an orthopedic standpoint, getting people back quicker with less risk, more safety, less pain, less use of opioids. I mean, one big thing in healthcare is that there has been an extreme focus on the opioid epidemic, which has made each one of us a better doctor because we just prescribe less pain medicine. And that's taking better care of patients. The research and science in the United States and in the medical centers, the academic medical centers like the Mayo Clinic, Cleveland Clinic, Stanford, Yale, Duke, the research that our universities are doing, and even the research that our group is doing is literally improving healthcare. So there's a lot of good things about healthcare, and it's still a very noble profession. It's still a very rewarding profession. But, one of the big things is there's a lack of doctors. And why? We talk about this. We've started a task force in our community with healthcare leaders, and it's basically called a healthcare, education initiative, really designed around trying to increase the workforce in healthcare. But one of the big things we've talked about is health. The healthcare industry has lost its respect. It used to be a very noble profession. For some reason, it doesn't have the same level of respect. And when someone says, "Oh yeah, I'm in healthcare, I'm a doctor," it's just not the same as it used to be. My father was a physician. And when I started, it really meant something different, I think, to the public than it means now.
Why do you think that is?
I think there's been a lot of fraud and abuse in healthcare, and people have taken advantage of the system, so that's given it a bad name. Doctors are tied in with healthcare. When in general people hear healthcare, they hear expense. They hear high cost of healthcare. They equate me and my colleagues with being part of the high cost of healthcare. But what I can tell you, and this would be a fact, that if you have a procedure done by me, I am probably the lowest cost of that procedure in general. There's a lot of other things. The cost of healthcare for physicians, we can overutilize and overprescribe and just overuse and order too many tests when you don't need those tests. So that we do on our side contribute to the overutilization and increased cost of healthcare. But I think the world and lay people not in medicine believe that medicine is a very expensive proposition. I think they believe that there's greed behind it, and that the foundation of medicine is not as, for lack of a better term, as pure and as holistic as it used to be. And part of it is because medicine has become a business. It's become a business.
Right.
It's a business. So
that's what when you're having as a physician to wear both hats, and entrepreneurs out there wear a lot of hats, right? And to some extent you're an entrepreneur, right? And you're a physician, but you're running a business, and so you have to wear a couple of those hats. But when you layer in regulation and coding and admin and lawsuits and malpractice and all the other things that you face as a physician, it starts to separate you from the typical mom and pop entrepreneur. And maybe healthcare perception, or the perception of physicians, has changed because out of necessity. I mean, they've had to become shrewd. They've had to become business people that are out to make money because everybody's trying to take money from them, from reimbursements to lawsuits. And so, or dwindling reimbursements to lawsuits. And so, we have to look at that too. It's a problem. And so,
Mike, 60 to 80% of doctors now are not going into private practice. They're going to be employed physicians. And maybe people like me are the crazy ones. We're the ones that are still trying to bang our heads on the wall and still make a margin and make a living. And trust me, I'm very blessed beyond belief, but to continue to try to fight the regulations and the world that exists now, I have a daughter that's just got accepted into medical school. She starts med school this fall. I can't imagine she would go into private practice knowing what I know. I just don't think 5-6 years from now, or actually med school and residency 9-10 years from now, I don't even know. I hope that private practice exists, and Ortho Alliance will allow us, hopefully long-term to be in private practice, but whether or not as many private practices will exist, I doubt it. I doubt it. It's a battle that's really tough to fight. And that's why the majority of people now become employed. And I think their lives are easier. They literally can focus on being doctors. And if your goal was primarily to be a doctor, then I think that's a great choice for you. But I also did have an entrepreneurial spirit, and South Bend Orthopedics provided the ability for us to be entrepreneurs. And so I chose this group. It was a wonderful group. But to be entrepreneurs is very tough. It is.
Yeah.
Yeah.
Well, it's interesting you say about being able to focus on being a doctor if you're an employed doctor. But I've read some stats that physician-owned specialty hospitals or physician hospitals have much better outcomes than traditional hospitals. So, I don't know what that means, but there's got to be something to be said for that too.
I think it means that if you allow doctors to be involved in every step of a clinical pathway and allow doctors to cut out the waste in the system and allow doctors to choose things that we know will give good outcomes, I think that's why physician-owned facilities, surgeon-owned facilities for what I do, they do have higher rankings and better outcomes and less. It's just because physicians, that we are the ones that determine the clinical pathway. And if we are in ultimate control of it, I think patients do better. Not to say that large box hospitals have horrible outcomes. They don't, but we're talking a percentage point here or there. And our outcomes and our satisfaction are higher. Just because I think we're directly involved in the decision making.
So to switch gears a little bit here,
Yes.
because you mentioned something about technology earlier on in the conversation. There's a lot of talk about telemedicine. Is there any, outside of it, EMRs, is there any technology that you've seen recently that you're excited about?
I think that in orthopedics specifically, the use of robotics is huge. And people, the world thinks that robots are actually doing the surgery for the surgeon. That's not the case. I mean, the robots have the ability to make the margin of error in surgery much narrower. So for a very good surgeon, the robot makes him a degree better, a millimeter better. But let's just say for the average surgeon, it allows the zone of error to be smaller. So I think robots are here. They're here to stay. Patients ask for them. People ask for them. They ask for the name of the robot, the specific robot. So patients are savvy, and I think they should ask for them because the results are slightly better with robots. I think it's been proven. The outcomes are better. The surgical times are less. The efficiency is better. Just overall, there is definite improvement, especially in joint replacement and spine, and in the world of neurosurgery as well as general surgery. Robots are vital. And then technology. People think of technology as computers and implants and stuff like that, but the world of orthobiologics, using, I do believe, stem cell research, stem cells, biologic factors, those are things that can enhance recovery and enhance healing. So I think the technology and the science behind orthobiologics is huge in what I do. So I've been a firm believer in orthobiologics. So that is here to stay. And I think as companies invest more money in biologics, I think that we'll give patients better outcomes. And the other thing is, we invested in a company, and we created a startup company. There is also technology to help us analyze our data more quickly in a more rapid manner so that we can prove outcomes. And so I think that healthcare, groups and private practice groups, and hopefully, and I know with Ortho Alliance, the technology of analyzing data is better and it's more rapid. I was talking to, when we formed a startup with another private equity company, I said, well, tell me, our goal was to combat, just insurance denials and things like that. I said, so if we have people that process a denial, process a claim, and we have one person, how long does it take them to analyze and process a denial? He said, a couple hours. I said, well, with your analytics and your computers and your artificial intelligence, how many claims can your computers and AI do? He said, as many as it needs to, thousands in 2 hours. So that technology has me excited. So that is to come, and I think that may be one of the saving graces of private practice. So we'll see. I think those are the technology things, but man, the technology that's going to be out there 10, 15 years from now, I never thought I'd see half of the stuff that I see now. I can't wait to see what happens 20 years from now. It will be amazing. And that's what makes American medicine and worldwide medicine unbelievable, because just the leaps and bounds that occur every decade are unbelievable. So,
yeah, I was, technology, and there's a lot of analog with healthcare. So, we talked a few months ago about some of the issues you were having with your caller, or your the
call
folks
center.
that answer, your call center, and not being able to find employees to do it, and then just having like people wait on hold forever. And then you have a website where you could schedule things, but a lot of your patient base isn't comfortable booking on the internet. They want to talk to somebody. They want to make sure that, they might be driving an hour. They want to make sure that they've really got their appointment. So there's all this things that you can't really solve for necessarily with technology. And so there's this analog part of healthcare, but that when you get into the real technical side of things, it's really amazing. And maybe like this chat GPT that's out there can help with some of this stuff. Cause I've talked to other physicians about this call center stuff, and it's like, it's so basic, but it's so important. And I'm just curious about telemedicine, which I mentioned earlier. As a real estate developer and owner of medical office buildings, we sometimes get questions from our capital partners or investors. How is telemedicine disrupting space and the need for space? And I'm just curious to see what you think of telemedicine and how it plays a role, and whether or not that's really a condenser of actual medical office space that's needed, or it's just another amenity of having a medical office building that you're in.
I think I think it's exactly the opposite of what your partners are concerned about. I think that what telemedicine does is it decompresses my live office visits. So I put more office visits in. So I think it's the opposite. I think that what telemedicine, at least in my surgical specialty and in my group, it allows us to see more patients. In fact, I think it decompresses, the office space and allows us to see more. So I don't think it changes our space utilization whatsoever. But that being said, for me, telemedicine, I don't know how to diagnose a medical problem without actually laying my eyes on someone. Can you imagine, and I do telemedicine all the time because I take care of people that go back to college, in the community or the city that they're in. And when I'm talking to someone, I said, hey, how's your surgery doing? And they go, see right here, the scar's right here. I just don't like practicing medicine like that. So I'm not a big fan of telemedicine, but I do believe that it provides in many cases for people that need chronic healthcare management for diabetes, blood pressure, and their physicians can talk to them and educate them more. I think it's good. So there is a place for telemedicine, but from a medical, and me, I do enjoy the medical real estate type stuff. It's not changing our need for space. I think that it allows doctors to be even more productive. So we still need our space.
Good.
Yes, and we are trying, as you know, we need to find more space and build more space and expand into space. So I don't think anything's changing about that. It's not like a business like a stockbrokers or people in the financial industry. They don't necessarily need space because they found that they can function without space. We need space.
Good. Music to my ears. So, and you've been a great tenant, by the way.
Thank you. So we pay on time.
You pay on time, yes. We have a $50 per day late fee, and so far
Perfect.
You haven't hit it.
Perfect.
So it's great.
Awesome. I didn't even know that.
I'm just kidding. But I was going to ask you about. I heard a stat today about hospital systems. So in 2019, Moody's and S&P had hospital systems and healthcare facilities as the lowest risk for bond defaults. In 2020, it ticked up a little bit. In 2021, it came back down. In 2022 and 2023, hospital and healthcare systems and facilities are one of the highest risks for defaults. And the stat
They
I
are
heard
the
today is that
highest risk.
one of the highest risks for default. Now that lumps in every hospital system. So that could be critical access hospitals, that could be rural hospitals, it could be some of the big systems, the not-for-profits, the for-profits. So it's everybody. The stat I heard today, though, was that 53% of hospital systems are experiencing a significant cash crunch and significant operational financial deficiencies. And so you're close. Obviously, you're independent practice, but you're close, I imagine, to a lot of hospital system executives and people in your industry. And I'm just wondering if you've heard a lot of consternation from hospital system CEOs or C-suites about what they're facing and the challenges that they're facing right now.
I think that what you just described is exactly what I've heard from my friends in that business. I I can't believe, or I can't begin to understand why I think that change has occurred over many short years, but it's a workforce problem, it's a volume problem, it's maybe a financial discipline problem. I think it's multifactorial. But if you step into a hospital, you will realize that if they're not doing the volume they need, that's a lot of bills to pay. And but the other thing is, and it's truly a trend in healthcare. That's a real trend. Is things are moving away from the hospital. As much care as people can get outpatient through telemedicine, through frequent visits to their primary care physician, outreach clinics. The world is trying to go around hospital care, and I think it part of it is cost, but I also think it's very efficient to meet people in their community, meet them on telemedicine, meet them in the office, and it with better population health, pop health, and preventative health care. I think hospitals maybe are not as necessary. They're still very necessary for certain procedures, certain patients, and high risk things, and certain specialties. Um, but things are going outpatient. Things are going outpatient surgery centers, outpatient healthcare. So
Yeah, and we're
it's not
we're seeing
surprising.
that. No, and you have to look at what CVS is doing with Village MD and what
Yes.
Amazon is doing with One Medical and go, well, those guys are pretty smart and they've got a lot of money and they chose to spend a lot of it on healthcare. And so being where the patient lives, works, and shops, we've seen this retailization of healthcare where it's not on campus, it's off campus, it's the hub and spoke model, but it's really let's be somewhere where there's a big patient base and we know they're shopping there. We know there's restaurants nearby. It might be in a CVS. It might be in a strip center. It might be an outlet to a power center. Let's give people options so they're not coming onto our campus. And primary care is a huge driver for your business, I imagine, and it's going to be a big driver for a lot of other specialties. But you touch on something, and I'm not sure if we have time to get really into this because it's a super, super deep hole. But looking at the root of the issue with healthcare in America and the fact that it's $4 trillion and it's 18+% of our GDP, why is it? And you got to be honest and say it's because a lot of Americans are unhealthy. And is it access to healthcare? Is it insurance? Is it reimbursements? Is it all this stuff? But we've got to figure out a way that everybody can get healthcare and we can start preventing some of these longer term issues that are causing a lot of this cost, which then trickles down to a lot of other things in the system. And so that's for another podcast. But um, I really want to thank you for your time. It's been great. I don't know if there's anything else that you've got on your notes that you'd like to cover.
I we've talked about this. What is the one thing that I think could be improved about healthcare? I mean, it's certainly access, it's certainly insurance issues, it's facility issues, it's this and that. But if we could get back to making the patient the focus of healthcare, but also the providers also need to be a focus, and making sure that we have good, healthy, strong providers and a provider base to take care of patients and take care of patients well. I think that's part of what's been missing. It's definitely been about patient care, patient experience, but man, providers also need a decent experience and decent happiness and life satisfaction to continue working very hard. And I mean, and if we don't solve for the physician burnout problem, healthcare will decline. And you think access is bad now. I mean, what happens if just 20% of physicians just drop out of healthcare and do something else? So I hope that we can bring back the focus to providers too.
Well, there has to be some parity in healthcare and providing care to people that need it. I mean, if you've ever been sick, you realize how important healthcare is. And
yes.
I'm a capitalist, but I have empathy. And if you can't afford healthcare, there should still be a way for you to get it.
I 100% agree with you.
We live in America. There's no reason why we can't provide healthcare to people that need it. But there has to be a capitalism side to healthcare as well, where you have physicians that are effectuating amazing outcomes. You need to reward those people for doing it. And if physicians aren't, then they shouldn't get as much of a reimbursement. And so there's got to be a business side of healthcare, and there's got to be a healthcare side of healthcare. And so, hopefully with conversations like this and with people like you, we can effectuate some of that kind of change in the industry. So yeah, I think we solved all the problems today.
Well, maybe 1% of them, but we definitely talked about a lot of them. This was awesome. I hope we can do it again.
Yeah, me too.
This is the type of stuff that affects change. So I agree with you. So thank you. Thank you for having me.
Thank you. And enjoy the rest of your Basil Hayden's.
It's almost gone.
I will make sure that I link all of your education, which, by the way, is lengthy. Let me just show the audience here. This is just the first page, second page.
Oh, no.
Look at all these bullet points of speaking engagements and papers written, all kinds of good stuff.
It's just a resume stuffer. I was told to put a lot of stuff down. It's impressive.
Well, it will all be in the show notes, and you are very impressive. Thank you for everything, Dr. Mencias, and I'll talk to you soon.
All right. Take care.